Welcome to today's webinar entitled ACA Impacts and Market Trends on Consumer-Driven Accounts. Before we get started with our presentation today, I'd like to share some general information with you. First, Flexible Benefit Service Corporation and Paycor are excited to have partnered and co-sponsored today's event, which will be the first webinar in a series of 4 webinars that will be jointly sponsored by Flexible Benefit Service Corporation and Paycor during the months of September, October, and November. We at Flexible Benefit Service Corporation will use our expertise to present you some information on the ever-changing Affordable Care Act, and Paycor will use their expertise to present valuable information to you related to the new Department of Labor overtime rules. Each of these webinars, including the one you are attending today, has been approved for 1 general HRCI recertification credit, as well as 1 SHRM professional development credit. The certificates of completion will be emailed to you within 3 to 5 business days after each webinar concludes. In addition, in regards to the audio portion of today's webinar, you can hear the audio by dialing into the toll-free number that was provided to you or by listening through your computer speakers. If you have accessed the audio portion by phone, please be advised your phone line will be muted throughout the webinar to eliminate background noise. If you have accessed the audio portion through your computer speakers, please be advised the quality of the audio can vary based on the speed and connection of your internet. So if the audio starts to fade or get choppy, we encourage you to dial in by phone. I do apologize that a hard copy of the presentation could not be made available to you in advance. However, we will be emailing you a copy of the presentation along with the applicable HRCI and SHRM certificates of credit. Should you have questions during today's webinar, please enter those into the chat or Q&A function within the webinar platform, and we'll address as many questions as we're able, but unfortunately due to the number of attendees, it's unlikely we'll be able to answer every question today. Now, the last thing I'd like to do before we move into the ACA Impacts and Market Trends on Consumer-Driven Accounts webinar is formally introduce myself to you as today's moderator, along with providing you with some brief information on Flexible Benefit Service Corporation and Paycor, your co-sponsors today. First, my name is David Lindgren. I am the Senior Manager overseeing our Compliance and Public Affairs divisions at Flexible Benefit Service Corporation. I have approximately 16 years of experience within the employee benefits industry. Now, in regards to our organization, the one I work for, Flexible Benefit Service Corporation, we were founded in 1988, and we are located, our headquarters is in Rosemont, Illinois. We have really 2 primary business divisions within our organization. Our first business division serves as a third-party administrator, offering consumer-driven accounts and compliance services to employers throughout the country. We administer health and dependent care flexible spending accounts, health savings accounts, health reimbursement arrangements, commuter plans. We are a third-party administrator of COBRA, and we also do provide plan document services to help satisfy the ERISA summary plan document requirements using what we refer to as a WRAP document. We also do have cafeteria plan documents and cafeteria plan administration services available, along with a lot more. In regards to our reimbursement accounts, we do have debit cards available so that an employee does not have to wait for reimbursement and they can directly pay a medical provider. We do have a great benefits portal with a number of different resources available to plan participants. We have a newly launched mobile app, and we have a number of different other resources available. As it speaks of today, we have approximately 3,200 employer clients throughout the country, amounting to approximately 200,000 plan participants. Another division within our corporation is referred to as a general agency. Some people also call us a wholesale insurance distributor. Under this department, we contract with insurance producers throughout the country, and we offer them with concierge-like services to help assist them in managing their employer group clients, individual clients, and Medicare clients. We do have a number of different back-end resources for insurance producers as it relates to sales, customer service, marketing, and other business functions. Now, our co-sponsor today is Paycor. They are an owner-led, employee-owned company. They've been around since 1990, approximately the same time as our organization, and they have over 31,000 clients throughout the country. They have a suite of a number of different services, and they specialize in things such as payroll. They have an HRIS system. They offer onboarding and applicant tracking services. And as it relates to the Affordable Care Act, they do help employers comply and satisfy the new ACA reporting requirements under Code Section 6055 and 6056. What Paycor is known for is customer service, and I can vouch for that. We have a number of great relationships and friendly personnel that work over at Paycor that we deal with regularly. They have a great technology platform as it relates to their services, and their goal is to help clients reduce costs, engage their employees in the overall business, and improve analytics as well as compliance for employers. With that being said, we can now switch gears and move into our core presentation today, ACA Impacts and Market Trends on Consumer-Driven Accounts. Now, I'm sure many of you have had some level of training and education as it relates to the Affordable Care Act as a whole. But as you may be aware, there are a number of different market reforms that apply to medical plans and the health insurance coverage that employers offer to their employees. And this is just a list of some of those market reforms. By no means is this an exhaustive list, but things like as of the passage of the law, employer plans are now required to cover children up to age 26. You can no longer have a waiting period for newly eligible employees, such as new hires, of more than 90 calendar days. Plans generally must now cover essential health benefits, a list of 10 categories of benefits with unlimited annual and lifetime dollar limits. Health plans must have certain patient protections, such as covering emergency care that's received out of network at the in-network prices. Preventive care, generally for non-grandfathered plans, must now be covered at 100% in-network with no cost sharing for the member. Non-grandfathered plans are also subject to certain out-of-pocket limits that adjust for inflation each year. There's a new summary of benefits and coverage document that's required for all medical plans to be given to employees at certain times. And one of the bigger things, or I should say two of the bigger things, are the so-called employer mandate that generally requires employers with 50 or more employees to offer health insurance coverage to their full-time employee population that's considered affordable and provides minimum value, or potentially risk making a penalty payment. And along with that employer mandate comes some employer reporting that had to be completed for the first time this year based on 2015 coverage. So that's a whole lot that we just covered there, and that's just a snapshot of some of the ACA market reforms. And we know that the ACA has had a significant impact on employers and the medical plans that they offer. And I know a lot of time has been spent by HR professionals, insurance producers, business owners, and anybody that has a stake in the medical plan management in making sure the plan is complying with the new requirements. And a great deal of time, as I mentioned, has applied to the medical plan. Now, don't overlook how the ACA has impacted other plans, including consumer-driven accounts, which we define as your health flexible spending account, also known as an FSA, your health reimbursement arrangement, also known as an HRA, your health savings account, also known as an HSA. So our focus today is really going to be to provide you a breakdown of what these plans really are and defining those differences, talk about how the ACA has impacted those plans, and then talk about some current trends as it relates to these plans today. Now, one of the reasons we want to really focus on this is because the consequences of noncompliance can be severe. So you'll really want to make sure you are aware of the impacts. Just as an example, in some instances, penalties for noncompliance can be as high as $100 per employee per day. So I summarized some of this today, but just want to sort of put this in writing for you. But our goals for today are first going to be to define each type of consumer-driven account. It can be easy to mix up what a flexible spending account is versus a health reimbursement arrangement versus a health savings account. While there's some similarities and some overlapping, it is easy to get some things mixed up. So just want to give a refresher there and then dive into how the Affordable Care Act really has impacted each of these consumer-driven accounts. And that's really going to set the stage for us to review current trends as well as future trends that impact these consumer-driven accounts, or CDAs as we refer to them as. So we're going to start today with the Health Flexible Spending Account, or the FSA, and talk about the ACA impacts on that particular consumer-driven account. So the flexible spending account, just to give a general overview of what it is an employer-based account that allows employees to set aside money to pay for qualified medical expenses. And why would an employee want to do this? Well, the simple answer is that contributions to an FSA avoid income as well as payroll taxes. So in general, you're avoiding the federal income taxes, the state income taxes, the Medicare taxes, as well as the Social Security taxes. While these accounts are primarily funded through employee salary reductions, employers are also able to contribute to the account, and we'll talk about some of those restrictions that apply there here momentarily. But as it relates to the administration of the FSA, employees must generally submit information to the plan administrator to substantiate a reimbursement or a direct payment through the FSA. So in many instances, an FSA does have a debit card that comes with it, and payment for a prescription or an office visit or a hospital visit may be paid directly to that provider through use of the debit card. However, the employee oftentimes will still need to submit information to the plan administrator under IRS rules in order to confirm that that medical care was medically necessary. And for those where a debit card is not in use, the general process is submitting a claim, and then a reimbursement is triggered, assuming the expense is eligible. Now, in talking about eligible expenses, there is not an exhaustive list, so there's no resource for us to go to that gives us a definitive list of every eligible or ineligible expense. But what the IRS has told us in terms of eligible expenses is that we can generally look to the Internal Revenue Code, in particular Section 213D. And within there's a definition. And that definition says that a condition is considered a qualified medical expense if that expense was incurred for the diagnosis, cure, mitigation, treatment, or prevention of disease, or for the purpose of affecting any structure or function of the body. And this also includes transportation essential to medical care. So that gives us a very good definition, but there could be potentially some subjectivity there as to whether or not an expense is considered eligible or ineligible because we don't have an exhaustive list. Now, one thing I do want to point out is that the medical expenses that are out of pocket related to a health insurance plan, such as copays, deductibles, and coinsurance, those expenses most certainly will be eligible, but the eligible expenses also extend beyond the medical plan. So that will include out-of-pocket expenses related to things like dental, orthodontia, vision, contact lenses, eyeglasses, LASIK surgery, hearing. Those types of things are all eligible. But the regulations do make it clear that two items are not eligible. And these are also items that do fall under the definition of Section 213D, but the IRS has specifically said that these are not eligible through an FSA. And that would be insurance premiums of any kind, as well as long-term care. So keep that in the back of your mind if you were unaware. Now, general rules as it relates to the FSA, I've got 5 or 6 of them here for you. The first rule is that in order to have an FSA, you must have a plan document in place which describes the terms of the plan, things such as eligibility. Another general rule is that elections into the FSA are irrevocable, meaning if an employee decides they're going to salary reduce $1,000 to their FSA, they cannot change, they cannot reduce or increase that $1,000 election. They're stuck with that election until the end of the plan year. Now, there are exceptions to that for certain qualifying events, things such as getting married or having a child. Those would be things that would allow you to make a plan election change, but only if the employer and the plan document that they have allows such changes. Employers do not have to allow for all plan changes or any plan changes for that matter. Most employers that we work with do allow for the whole spectrum of plan election changes, but that really is a preference of the employer and how they want to administer the plan. Another general rule as it relates to the FSA is that there's a phrase uniform coverage that applies. And what that means in layman terms is that the entire FSA election must be made available to the employee at the start of the plan year, or if later, the first day that they're enrolled in that FSA. So if they elect $1,000 into that FSA, that $1,000 is made available to them day one, even though they will make payments for that generally through salary reductions throughout the course of the year. Use it or lose it is another general rule, and that's where unused funds at the end of the plan year are typically forfeited back to the employer, and the employer can use those to offset any administrative expenses associated with the FSA. There are some exceptions that apply that we're going to talk about here momentarily. And the last general rule is that non-discrimination does apply to the FSA, and the non-discrimination rules are in place so that the plan is not designed to favor highly compensated employees. Now, some of the key impacts as it relates to the Affordable Care Act and how it has changed or modified some of the FSA rules. The biggest one would be the salary reduction limit. As of 2013, employers must not have a salary reduction limit for employees that exceeds $2,500, and that number is adjusted for inflation. In 2016, or for the 2016 plan year, I should say, the maximum salary reduction allowed is $2,550. Employers do have the option of setting lower limits, but they cannot establish a limit that exceeds $2,550. Now, that $2,550 is a salary reduction limit. That does not include employer contributions, so employer contributions can be made above and beyond that $2,550 limit, subject to some restrictions and maximums that we'll talk about here shortly. Now, as it relates to the $2,550 limit, we do have a couple common questions that we receive. The first is if an employee has multiple jobs, and they have access to an FSA at each employer, what is their salary reduction limit? And under the IRS guidance, they indicate the employee can contribute the full salary reduction limit to both employers' FSAs, assuming that the employers are not part of the same controlled group, as defined in IRS Code Section 414. Another question that commonly comes up is if there are spouses that are married and both spouses are eligible for an FSA, can they both contribute to the FSA, and if so, how much? And under the IRS rules, they do say both spouses can contribute the full $2,550 limit to their respective FSAs. So each would have the ability to do $2,550, even if they were employed by the same employer. Now, another significant rule that impacted FSAs was that over-the-counter drugs, in order to be an eligible expense to be reimbursed out of the FSA tax-free, now require a prescription. Even though the over-the-counter drugs, things like Tylenol and NyQuil, don't require a prescription for someone to purchase them from a pharmacy or grocery store or wherever, they do require a prescription in order to be considered an eligible expense for tax-free reimbursement under the FSA. Now, as a result of the $2,500 salary reduction limit, which again is inflation adjusted to $2,550, there was some subsequent guidance that was issued that for the first time now permits a $500 carryover option that employers can tie to their FSA. And this came out, I believe it was Halloween 2013, the guidance was issued. And prior to that, there was no carryover option available. Funds were typically forfeited back to the employer. But going back to that Halloween 2013 guidance and moving forward, the new rules say at the option of the employer, unused funds of up to $500 can be carried over into future plan years. And more recently, some follow-up guidance has been issued, which indicates employers can place some restrictions on those carryover balances. As an example, they can tell an employee they can only roll over funds for one plan year, or they can indicate that rollover funds or carryover funds are only available if an employee makes a new election into the FSA in the following plan year. Now, I haven't seen many statistics nationally, but here at our organization as an FSA administrator, since this guidance was passed back in 2013, 95% of our employer clients have implemented the FSA option. So it seems to be the norm as part of the FSA package that employers are now offering to employees. Now, this was not a part of the ACA, but I thought it was still important to bring up during this slide, is that something referred to as grace period is still an option for employers. And this is where medical expenses can continue to be eligible for reimbursement for up to 2.5 months after the plan year ends. As an example, if your FSA started January 1st, 2016, your employees could submit eligible expenses, or claims would be considered eligible for medical expenses incurred between January 1st, 2016 and March 15th, 2017. So this is an option, and just to point out, you cannot have both carryover and a grace period. It is one or the other, but employers need not have either. So there could be no carryover and or no grace period if that's the way the employer wishes to structure their plan design. Now, another significant piece of guidance came out from the IRS in the form of what's referred to as Notice 2013-54. And this indicates that FSAs for plan years starting January 1st, 2014 and moving forward must meet the definition of what's referred to as an accepted benefit. Accepted benefits, in general terms, are things that they feel like they might have a medical component to it, but they're not directly health insurance. They're not regulated like a health insurance plan. Things like dental insurance, vision insurance, FSAs if they meet certain guidelines, disability insurance, life insurance. If they can fall into this accepted benefit category, then they virtually get a pass from most of the Affordable Care Act requirements, if not all of them. And as of January 1st, 2014, going forward for those plan years, so as we are here today for current plan years and those plan years in the future, 2 conditions must be satisfied in order for the FSA to be considered an accepted benefit and to get a pass from the ACA market reforms. And the first is referred to as an availability condition. And in general, this means that the only participants on the FSA can be those who are also offered a medical plan by virtue of employment. So if you're not offering a medical plan to your part-time employees, that means, based on IRS Notice 2013-54, you should not be offering your part-time employees an FSA. There's also the so-called maximum benefit condition, and this is what places restrictions on employer contributions. As we've discussed, the salary reduction limit was set at $2,500, inflation adjusted to now $2,550. And under the maximum benefit condition, if an employer is going to contribute on top of the employee salary reductions, the maximum benefit condition says the employer contribution cannot exceed $500 or a dollar-for-dollar match of the employee salary reduction, whichever is greater. As an example, if an employee put $1,000 into their FSA, that employer can contribute up to $1,000 to that employee's FSA. However, if an employee waived the FSA and did not contribute anything into the FSA, the most an employer could contribute would be $500. Another thing that Notice 2013-54 also told us was that FSAs now must be a part of your cafeteria plan, of your Section 125 plan, whatever you refer to it as. And if it's not part of your cafeteria plan, that means you as an employer cannot impose any annual dollar limit on the amount of reimbursements. And by design, FSAs are not structured to be that way. They're meant to reimburse up to the maximum salary reduction plus any employer contribution. But under the ACA, they say plans which are not accepted benefits cannot impose any annual dollar limit on the reimbursement. So you'll really want to take a look at your plan documents, your cafeteria plan documents, to make sure your FSA is listed as one of the eligible benefits. It's usually not intended. It's really just a matter of error or oversight that the FSA is not listed as an eligible benefit in the cafeteria plan documents. So that's something you'll really want to check again, it's usually an unintended consequence by error or omission. So if there's one takeaway, this would be one I'd like you to have, to go back and check your plan documents and make sure your FSA is included in there so you're not subject to having to reimburse employees for an unlimited annual dollar limit. Now let's move on to our health reimbursement arrangements, or our HRAs, and discuss them in general, as well as the ACA impacts on this particular consumer-driven account. So to give you some background on an HRA, or a health reimbursement arrangement, it is an employer-funded account which allows employees to be reimbursed for qualified medical expenses. Reimbursements for those qualified medical expenses are tax-free to the employer as well as the employee. One difference with the HRA versus the FSA is that the HRA must be solely funded by the employer. It cannot be either directly or indirectly funded by employees. It's exclusively employer dollars that go into the HRA. And just like the FSA, though, employees generally must submit information to the plan administrator to substantiate either a direct payment made with a debit card or a reimbursement if a debit card was not available. So there does have to be a third party that validates that the expense is eligible and was medically necessary in order for that reimbursement to be made available. Now, similarly to the FSA, the eligible expenses that are available through an HRA are typically defined within that Internal Revenue Code Section 213D that we discussed earlier. But that is really the maximum amount of eligible expenses. Employers oftentimes set some narrower definition, which is permissible. So the employer really is able to define which is an eligible expense within Internal Revenue Code 213D. In addition, the employer sets the annual reimbursement limit within that HRA, so they are not subject to any limits by the IRS or any other agency. An employer could have, a $1,000 limit, a $10,000 limit, a $20,000 limit, whatever they may choose. That limit is defined by the employer on an annual basis. Now, with the HRA, the way they are oftentimes used is they're directly tied with the health plan. And in some instances, they have to be, but oftentimes an employer may structure the HRA so that the eligible expenses are only those for some or all of the medical plan deductible. Or they may structure that HRA so the eligible expenses are tied to more global out-of-pocket expenses that are tied to the medical plan, such as the deductible plus any copays or coinsurance. Alternatively, they can make eligible the maximum number of expenses and allow anything under Code Section 213D, which would extend, again, beyond expenses tied to the medical plan, and it would include things like dental, vision, and hearing. But speaking of dental and vision, some employers do see HRAs as a great alternative to insured dental and vision plans and find it being a more cost-effective and valuable benefit to offer dental and vision in the form of a health reimbursement arrangement. So those are some common options, but there are some flexibility in other types of options and eligible reimbursement expenses. Now, as it relates to some general rules around the HRA, similar to the FSA, the employer must have a plan document which describes certain things, such as who is eligible to participate in the HRA. Unlike an FSA, uniform coverage is not required, so the employer does not have to make the entire annual limit available to their employee population day one. Some employers do structure this so there's a maximum monthly reimbursement, or it could be a maximum quarterly reimbursement, really up to the employer and up to their ability to administer that or outsource to somebody that's able to administer that. As it relates to unused funds after the plan year is over, really this is up to the employer to decide what's going to happen to those unused funds. They can be forfeited, which is probably the most common option, but they can also be carried over, again, depending on the employer's preference. They can allow the full unused balance to be carried over, a portion of the unused balance, a percentage of the unused balance, really up to the employer to define that and there are no limits on the amount of carryover. Similar to the FSA, non-discrimination rules also apply so that the plan is not designed to be structured in favor of highly compensated employees. Now, some of the ACA impacts, this also goes back to that notice that impacted FSAs, but in September of 2013, the IRS released Notice 2013-54, and this really limited the types of HRAs that an employer can offer. And I put these into 4 buckets. The names that you see in bold on your screen are not formal names. You're not going to typically see these in any guidance that's issued. These are names that really the industry commonly uses. But the most common type of HRA that is in place today and that is permissible under 2013-54 is something that's referred to as an integrated HRA. And in general, the only participants on this HRA are those that are also enrolled in the employer's group medical plan. So if that's the case, then that would be or if that's the structure of the HRA, then that employer would typically satisfy the requirements of having a permissible integrated HRA. Another type of HRA is what we refer to as a former employee HRA. And this is one where, simply put, the only participants on the HRA are former employees, no current employees. Oftentimes, this would be an HRA that reimburses the retiree population. Then there is an accepted benefit HRA. This does not have to be tied to any particular group medical plan, but this is one where the only reimbursements are for accepted benefits. The most common would be an employer who wishes to use the HRA to reimburse dental and vision expenses as opposed to purchasing an insured dental and or vision plan. And then there's something referred to as a spend-down HRA. This was an HRA that was in place prior to 2014, generally speaking, prior to Notice 2013-54 being issued. And this would be an HRA that allowed for carryover balances of unused funds. And this type of HRA can remain in place until any account balances within that HRA are exhausted. They go down to $0. But the employer cannot make any new contributions to this. So a spend-down HRA is usually one that's not tied to any particular medical plan, doesn't meet the definition of an integrated HRA. It was in force prior to this notice, so the regulators said essentially we'll allow you to grandfather these plans. You can allow your employees to exhaust their funds, but no new contributions to it. Now, failure to offer one of these types of HRAs is going to make that HRA subject to all of the ACA market reforms. As an example, you could not place any limits on annual or lifetime dollar limits for reimbursements of eligible, or I should say essential health benefits. You'd have to cover preventive care at 100%. And that's not the structure that an HRA is intended to comply with by plan design. And so failure to offer one of these types of HRA is really going to put you in an area of non-compliance. So you're really going to want to make sure if you do offer an HRA or are considering offering one, it's going to fall within one of these allowable buckets. In addition, again, that IRS Notice 2013-54, along with many sets of subsequent guidance, has told us that HRAs cannot reimburse health insurance premiums in the individual market. There are some exceptions to that rule, and that would be for an HRA, a former employee HRA, again, most commonly the retiree HRA. You could reimburse those retirees for their individual Medicare premiums or even individual health insurance plans that they might purchase through the exchange, such as healthcare.gov. Just understand if it is a pre-65 retiree who's eligible for reimbursement under that HRA, they're not going to be eligible for subsidized coverage within that exchange. There's an exception for accepted benefit premiums, so you could reimburse through an HRA on a tax-free basis individual dental and or vision premiums. And there's also an exception in scenarios where An employer offers a group health plan, but they have employees that are also on Medicare. And if the employee were both on Medicare and the group health plan, Medicare would be primary. That's typically going to be your groups that have fewer than 20 employees, so your smaller groups. In those scenarios, there are some other requirements that need to be met, such as the employee must be offered a group health plan with minimum value. But if they waive that group health plan with minimum value, the employer could structure an HRA so that that did reimburse Medicare premiums, such as Medicare Part B, Part D, or Medicare supplement premiums. I also want to add that if you do offer a retiree HRA that is reimbursing insurance premiums, or it's reimbursing out-of-pocket medical expenses other than those for accepted benefits, the IRS does consider that minimum essential coverage. Minimum essential coverage is what you need to satisfy the individual mandate under the Affordable Care Act. And as a result, if you are offering minimum essential coverage, that is going to make that retiree HRA subject to Code Section 6055 reporting. So if that is something you offer, you want to make sure that you are reporting that information, as there are some penalties for failing to submit the reporting and failing to provide a copy of that reporting form to those retirees. And similar to the FSA, over-the-counter drugs, also under the HRA, based on new Affordable Care Act guidelines, do require a prescription for it to be an eligible expense. Now let's move on to health savings accounts, our next consumer-driven account, and go over some general information along with the ACA Impacts. Now, a health savings account or an HSA, unlike an FSA or an HRA, which is an employer-owned and an employer-managed account, an HSA is an employee-owned savings account. Works a lot like a bank account. And this does allow employees to pay for qualified medical expenses. And the primary reason an employee might be interested in having an HSA is that contributions, whether made by an employer or an employee, do avoid income taxes, both at the federal level and in all but three states at the state level, but they also avoid payroll taxes, those Medicare and Social Security taxes, as long as the employee contributions are made through salary reduction within the employer. I already mentioned this or alluded to this, but contributions can be made by both the employer or the employee, or a combination of both. But an HSA also has some eligibility guidelines in order for an employee to be able to establish an account. So I want to talk about some of those eligibility guidelines. With an HSA, an employee must be enrolled in what's referred to as a qualified high-deductible health plan, or a qualified HDHP. And the definition of that for years 2016 as well as 2017 is that the minimum deductible for a plan that covers a single employee must be at least $1,300. If the plan covers 2 or more people, the minimum deductible must be $2,600, twice that single amount. There are also maximum out-of-pocket limits for the qualified high-deductible health plan. Please note these maximum out-of-pocket limits are different and lower than the maximum out-of-pocket limit that's allowed under the Affordable Care Act. So these are limits specifically for a person to be HSA eligible. And for 2016 and 2017, that's $6,550 for single coverage, $13,100 for family coverage. Another requirement of the qualified high-deductible health plan is that what's referred to as first dollar coverage cannot be made available under the plan for anything other than preventive care. And when we talk about first dollar coverage, that's a payment by the insurer or the plan sponsor in the event of a self-insured plan that covers claims prior to deductible. So things like office visit copays that would only require a small fixed dollar amount to be paid by the employee, and the health plan would cover the balance thereafter. Those types of copays would not be permissible under a qualified high-deductible health plan, at least not until after the deductible has been satisfied. However, for preventive care, that can be covered at 100% with the health plan making all claims expenses payouts for that preventive care, no out-of-pocket to the employee. Now, another HSA eligible guideline is that if a person does have more than one health plan, they cannot be covered by another plan which is considered non-qualified. So, for example, being covered by an HMO or a plan that had a deductible lower than $1,300, or being covered by a government plan such as Medicare or Medicaid. Those types of plans would disqualify a person from being HSA eligible. And lastly, a person must not be claimed as a dependent by another person. So if a child has a qualified high deductible health plan, but they're being claimed as a dependent by their parent, that child would be HSA ineligible. Now, in terms of HSA contributions, there are limits that are regulated by the IRS. They do adjust for inflation on an annual basis, or at least they're reviewed for inflation adjustments on an annual basis. The maximum contribution for a qualified high deductible health plan that covers a single person is $3,350 this year. That's going to go up by $50 next year in 2017 to $3,400. The maximum contribution for a qualified high deductible health plan that covers 2 or more people, constituting family coverage, would be $6,750 this year. That's going to remain the same next year. And there is also a $1,000 catch-up contribution for anybody that's HSA eligible and who is age 55 or older. Now, with an HSA, there's no cap on the amount that can be carried over. So you can get that account each year. You can contribute the annual limit that's applicable to you, and you can not use any of that money if you so choose. And every single year you can contribute up to the annual maximum and get that account to grow to be as big as you possibly can. Now, what's unique about an HSA in comparison to an FSA or an HSA is that, at least depending on where the HSA account is housed, the funds within that HSA can be invested into publicly traded investment vehicles, things like stocks, bonds, and mutual funds. And some people have come up with a nickname for an HSA, and they're referring to them as medical 401ks. HSAs are being promoted as being a option, at least, for employees or even individuals who have an HSA outside of the employer of saving funds until they get into retirement, so that they then can use those HSA funds on a tax-free basis in retirement for things like Medicare premiums. So that's a nickname that's been used more frequently as of late. Now, similar to our HRA and FSA, there's not an exhaustive list of what is an eligible or an ineligible expense. Again, we can generally refer to Internal Revenue Code 213D. And that, again, does extend eligible expenses beyond the health plan. So your deductibles and coinsurance would most certainly be eligible, but things like dental and vision and hearing are also eligible. Some insurance premiums are eligible. Medicare premiums, other than those of a Medicare supplement, are eligible. So Part A, B, C, or D premiums would be eligible. Premiums that are paid for health insurance while collecting state or federal unemployment are eligible. Long-term care premiums are eligible, but only up to certain limits based on a person's age. And COBRA premiums are also eligible. One of the very convenient things of an HSA is that there is not a requirement for third-party substantiation. So an employee does not need to submit their receipt or their claim to the plan administrator to validate whether or not an expense is eligible or ineligible. The HSA guidelines require that employee to self-substantiate, meaning it's up to the employee to make sure they're using those funds for qualified medical expenses. And if they do use those funds for ineligible expenses, then they are typically subject to income taxes plus a 20% penalty. 20% penalty waived for people age 65 or older. So that's a convenient thing, but does pose an administrative requirement on the employee or the account holder to determine whether or not they are or aren't using their HSA for eligible expenses. Now, as it relates to the ACA, health savings accounts were not impacted nearly as much as the FSA or the HRA. Really, there's two primary things, one of which you've already heard. But there is a penalty, I mentioned already, for withdrawing funds for non-qualified expenses. Prior to the ACA, that penalty was income taxes plus a 10% penalty. The ACA increased that to income taxes plus a 20% penalty. And similar to the HRA and the FSA, in order for an over-the-counter drug to be an eligible expense for funds to be distributed or withdrawn tax-free, it does require a prescription from a doctor. Now that really wraps up our general definitions of what each consumer-driven account is and what the ACA's primary impacts to these accounts are. Now just kind of want to move towards the final parts of our presentation here and talk about some market trends. And, the first market trend, I hope it's not too surprising, is that consumer-driven accounts are really on the rise. They're growing at very rapid rates. There's expected to be 4.8 million new consumer-driven accounts, or I should say new participants, on an annual basis. Estimates out there are anywhere between 35 and 40 million FSA participants are enrolled today. That number is expected over the next couple of years to grow by another 2 million. As it relates to HSAs, they've only been around for about 12 years, but believe it or not, there's more than $30 billion in funds, accumulated in HSA accounts today. At least that's the estimate. And those numbers, depending on who you ask, are going to grow very dramatically over the next several years. And as it relates to the health reimbursement arrangement, there's expected to be around 19 million people covered by an HRA by 2018. And you may be asking yourself, well, why are these accounts on the rise? And I think it's pretty simple to answer that question. As many of you HR professionals know, or if we have insurance producers on the line, or business owners, or decision makers as it relates to the health insurance plan, this is a trend been going on for several years, escalated for some of you in some situations as a result of the ACA. But premiums have been rising. And so as premiums rise, both employers and employees are looking for more affordable health insurance plans. And so if you're looking for a plan that has a lower premium, the trade-off there, at least in many plan designs in many scenarios, is that's going to come with a plan that has a higher deductible and a higher out-of-pocket. And so if employees are taking on or are exposed to higher overall out-of-pockets, then it makes sense to consider a consumer-driven account, whether it be an HSA, FSA, or HRA, or a combination, so that coverage can be provided or out-of-pocket expenses can be paid in a more cost-effective way because of the tax benefits. So I hope that makes sense. And just another chart here to show you, this is a statistic that we grabbed from the Kaiser Family Foundation, just sort of reiterating the rising overall exposure to deductibles, is that from 2006 to 2015, the average deductible over this 10-year time period for employer-sponsored coverage increased by more than 250%. So that's a pretty big rise over a relatively short time period, and that is why it makes sense at least to consider one or more of the eligible consumer-driven accounts. Now, just to review some trends as it relates to each consumer-driven account, for flexible spending accounts, our analysis is that flexible spending accounts are getting close to full market penetration. We conducted a survey our firm did back in 2015 of more than 500 employers, and 90% of those employers indicated to us that they offer an FSA to at least some of their employee population. So that's a rather high number. And while that offer rate is high, we do believe that, as the statistics are showing, that participation is still going to increase, and we'll talk about that reason here in a moment. But the offer rates from the employer just a few years prior, going back to 2012, 2013, we're at somewhere around 75%. So pretty significant growth in the offer rate, 75% to 90% over a few years. And our analysis is that growth has been primarily attributed to, of course, increasing out-of-pocket exposure, but a greater interest in the account due to the carryover feature. Again, prior to carryover being made available, employees generally had to forfeit all of their unused funds, and now the carryover feature being available makes it a little more attractive and a little more easier for an employee to determine how much they want a salary reduce, because there's an understanding that if they contribute a little too much to their FSA, they'll be able to carry over up to $500 to the following plan year. Now, as it relates to the HRA and a trend here, we're seeing HRAs becoming very popular in the smaller group market segments. Everybody has their own definition for a smaller group market. I think it's probably more appropriate to say growing popularity in the fully insured market. And, the general use of an HRA here is you buy a high deductible health plan from an insurance carrier to get those lower premiums. But sometimes that can come with some resistance and some morale issues from employees because they perceive that high deductible health plan as being a low quality plan. And so as an employer, you can couple that or integrate an HRA in conjunction with that high deductible health plan to reduce some of that overall exposure, understanding that, if you have an HRA, in most scenarios, employees as a whole are not going to use all of the HRA funds available to them. Sure, some will, but some may not use any of those HRA funds, or some may use a portion of those funds. Oftentimes, utilization rates, it'll vary based on structure, but they can be, less than 40% or less than 30% of what you make available to those employees. So it works out well with getting a lower premium and helping those employees that do have higher overall out-of-pocket expenses. I talked about this type of HRA earlier, but the former employee HRA or the retiree HRA is really starting to become almost the norm for medium-sized and large employers, or for anybody that offers a retiree plan. We're really seeing more traditional retiree plans being phased out and replaced with a retiree HRA. Those retiree HRAs do not need to be integrated with another group health plan. So the most common structure would be to offer those retirees an HRA. They get a fixed dollar amount of funds that they can use, and they can use those funds to pay for their insurance premiums, including their Medicare premiums. So just a more cost-effective way for many employers to fix their costs, as opposed to having them remain on the medical plan and potentially being a higher claims utilizer, driving up premiums for the active employee population. In health savings accounts, we really see these being the leader of the pack going forward. They are the newest of the three consumer-driven accounts, only been around since 2004, so just 12 years into it. There's a lot of different studies and estimates and surveys out there, but there's several million people that have HSA accounts today, and some are estimating could be 45 million or more people that have an HSA account by as early as 2020. And I think as employers continue to offer more and more high deductible health plans, I think you're going to see a lot of participants, and we have seen some of those already migrate from an FSA to an HSA because the HSA has some more attractive features, such as higher contribution amounts and no cap on the amount of money that can be rolled over from one year to the next. I mentioned this earlier, talking about the HSA as having a nickname of being the medical 401k. And just to throw another stat out there to you, according to Fidelity Benefits Consulting, they put out a great statistic each year on this. The average 65-year-old couple retiring in 2015 can expect to spend $245,000 in retirement on medical expenses in today's dollars. And I think a lot of people, as they approach retirement, aren't thinking about using their more traditional 401k to pay for, $245,000 of medical expenses. So it's being promoted in the industry as being this great option to save for the medical expenses in the future. Plus, you have the ability to invest your HSA funds into stocks, bonds, and mutual funds. So just a few final comments before I open it up for a handful of questions. You may have heard of the Cadillac tax, and the Cadillac tax in general applies a 40% excise tax to values of health coverage that exceed certain thresholds. Now, this is something that's not scheduled to take effect until 2020, but employers will have to determine what is the value of coverage they offer to their employees. And that's going to include the total cost of the health insurance plan, but it's also going to include FSA salary reductions and employer contributions, the health reimbursement arrangement. They're going to tell us at a later date how to specifically calculate the value of coverage. It may not necessarily be the annual maximum reimbursement limit, but also employee salary reductions to HSAs made on a pre-tax basis or employer contributions to the HSA. And if that value is $10,200 for single coverage or $27,500 for family coverage, any amount of that value that exceeds those thresholds will be subject to a 40% excise tax. So there is a little bit of concern right now for how employers might react to offering FSAs, HRAs, or HSAs. However, on a positive front, both Democratic and Republican political leaders have both vowed to either repeal or change the Cadillac tax. Democrats have a lot of support from labor organizations and unions who have oftentimes have very rich benefit plans and would be exposed to the Cadillac tax. So many Democratic leaders are working to change or repeal the Cadillac tax. And then many Republican leaders are just outright opposed to the Affordable Care Act, and they would welcome just about any change. However, this being an election year and the Cadillac tax being delayed until 2020, our best guess is that it's unlikely that we're going to see any changes to it this year, and we won't see any changes until after the next president is elected and takes office. Now, despite the Cadillac tax, there's been a lot of guidance out there that's been proposed which would increase the growth of consumer-driven accounts. Just a few to name, there's the Small Business Healthcare Relief Act. This would be something that would apply to employers who are not subject to the employer mandate. And this would allow those smaller employers to offer an HRA which could reimburse health insurance premiums in the individual market. There's also something that was introduced referred to as the Health Savings Act of 2016. This bill would seek to improve HSAs, such as making more people eligible, including those that are covered by Medicare Part A. And then there's something referred to as the Health Savings Protection Act, which directly goes at the Cadillac tax, looking to carve out employee salary reductions to FSAs and HSAs from inclusion in the overall value. So I think it's a really positive sign that we're seeing bills introduced. We'll have to see if they end up getting passed and signed into law, but still a very positive sign as it relates to the consumer-driven accounts. So with that being said, that brings us to the end of our presentation today. Just to reiterate, your HRCI and SHRM credits will be made available to you by email within 3 to 5 business days. So you should see those either by the end of this week or early next week. In addition, we will be sending you an email with a copy of today's slide deck, along with some additional resources to you. If you do have questions, our phone number and website information is here. I do want to add that our next webinar is going to be presented by Paycor, and that's going to be in relation to Department of Labor overtime updates. That webinar is not yet available for registration. We expect it to be available for registration later this week. And by attending today, you will receive an email if you're interested in signing up. You'll have instructions on how to do that. As of now, I believe the date for the Overtime Updates webinar is going to be on October 5th, if you want to pencil that in. With that being said, if you do have a question, please go ahead and type those into the Q&A function. I will answer as many of those questions as I can. Again, it looks like a handful of questions about copies of the slide decks. We will send those out to you. There is a question in relation to the flexible spending account. If an employee is eligible for the medical plan but waives participation, can they still participate in the FSA? The answer is yes. The only way they would not be able to participate in the FSA is if they were not offered a medical plan by virtue of employment. There is a question about the integrated HRA. Does the employee have to be enrolled in the employer's medical plan or any medical plan? The regulations indicate the employee has to be enrolled in a group health medical plan. So not any medical plan, but it has to be a group health medical plan. And that could be a group health medical plan offered by the spouse's employer. Now, there are some other technicalities with that that unfortunately don't have time to get into on today's call, but we can provide you some follow-up information there. There is a question, what is the maximum out-of-pocket limit for HRAs? I don't know that I entirely understand that question there, but the employer can set the maximum limit that an employee can be reimbursed during the year. So that's not regulated by the IRS. That amount is determined on an annual basis. What is the maximum limit for the HRA? There's a question, if you have a short plan year for your cafeteria plan, are you required to prorate the annual limit for the FSA? The answer is yes. And there's also a question, does that apply to the dependent care FSA? The dependent care FSA is subject to a calendar year contribution limit of $5,000 for those people filing taxes as a single or married filing taxes jointly. If married filing taxes separately, it's $2,500 per spouse. So with dependent care, it's tied to the calendar year, not the plan year. And the last question I see is, can I cover no first dollar coverage as it relates to the HSA plan again? With the HSA, you need to have a minimum deductible of $1,300 for single coverage, $2,600 for family coverage. And what that means is the health plan cannot cover any claims of that participant until the deductible has been satisfied, other than for preventive care. So if you have something like let's say a $20 office visit copay, but the office visit is actually $100, that means the health plan's paying $80, the employee's paying $20. That would be considered a first dollar benefit. So in general, when I say no first dollar coverage, it means no copays for any benefits until at least after that minimum $1,300 deductible for single or $2,600 for family has been satisfied. Well, that being said, I believe we've come to our stopping point here today. Again, we will send out copies of your certificates of completion for your HRCI and SHRM professional development credits. We'll send some additional resources, and we'll send a copy of the slide deck. But be looking out for an upcoming email as well about the Department of Labor overtime update presentation, co-sponsored by Flex, but will be presented by our partner here, Paycor. So again, thank you for your time today. Hopefully you picked up a few things, and we hope to have you on an upcoming event. Take care.